seeing smaller tumors and earlier diagnosis. So why are we doing this? We're seeing this basically, number one, because we have better diagnostic capabilities. So our ability to find things at a smaller stage have increased tremendously. It's interesting to me because this is a field that is very technologically driven. The fact of the matter is that we've been able to convince many women that it is important to do mammograms. It is important to try to do serial exams on their own, breast self-exam, for instance. But it also means that our physicists who work on the technical aspects of mammography and sonograms have been able to increase the ability for us to see things at smaller and smaller levels. And this is wonderful because the smaller a lump is, or a smaller a lesion is, or something that's found before you can even feel it, makes so much difference in terms of the treatment. So you can offer gentler treatments, if you will, treatments that are not the radical treatments that we used to talk about. The traditional diagnostic imaging that we talk about is the mammography. Over the last few years, ultrasound, in other words, sonogram examination, has also become very important, especially in younger women who are getting screened, who have very dense breast tissue, and even as good as our mammograms are, and digital mammography has made such a big difference. It is clear that sonograms as an adjunct to the mammogram is very helpful. But the third thing that's come up recently has been the use of other diagnostic modalities. The most common one that most people have now heard about and are talking about is breast MRI. Breast MRI is extremely sensitive. One of the drawbacks is it's so sensitive that it often will bring up more things than we possibly can deal with in terms of how many lumps we find, things that are a problem for women to have to deal with in terms of too many false positives. On the other hand, the sensitivity is so great that it is being utilized more and more. And I think as any new technology comes through, as doctors become used to seeing those images, the breast MRI false positive rate, meaning finding something that really isn't real, is going to decrease with time. Here at New York Presbyterian, we started a number of years ago a program for Oncoplasty, and that is the idea of combining cosmetic plastic surgical techniques with radical cancer surgery. This is real cancer surgery that we do, and we never shortchange the patient because of the cosmetic issues. Issue number one is cure. Second issue is how to make that patient thrive after her cure and for long periods of time. Genetic testing has become very important now in terms of breast cancer treatment. A number of years ago, it was identified in a certain population of women that there was a genetic mutation that was carried, and it had huge implications because if you were a carrier, you pretty much were certain that you would get breast cancer sometime in your lifetime. You couldn't tell exactly when. It was a very rare mutation, but it gave us the first inkling of the idea that we could do something in a prophylactic sense. In other words, if you knew you have a gene mutation and if you know that you have an 85–90% chance of getting breast cancer someday in the future, you could actually use that information to do one of two things. One, you could then put yourself into some sort of a very rigorous screening program so that if that should happen to you, at least you would be ahead of the game and it would be identified at an earlier point in stage. That was issue number one. But it also opened up the door to perhaps doing prophylactic breast cancer or pre-breast cancer surgery, if you will. In other words, what you could then say is, well, maybe if I could just remove all the breast tissue that I have, which is at risk, because if you have this mutation, it doesn't mean that the tumor appears in one part of your breast and it doesn't appear in another part. That mutation can turn on any time, and any time in any breast cell that you have could actually become trouble. So this is where you started hearing about women, and usually it was younger women saying, all right, I'm not going to wait for something to happen to me. I'm going to do something proactive. breast cancer is not a disease of the breast, it's a disease of the breast tissue. But the skin overlying the breast can be saved. And so we actually started doing skin-sparing techniques long before anyone else was starting to do that. And as time went on, we started getting better at this. The incisions got smaller. And we started doing some research in terms of nipple sparing itself, because we were always very concerned that there might be some breast tissue left behind on the nipple itself. It was just a technical issue. But on the other hand, we also knew that if we could save the nipple somehow instead of just reconstructing it, that the visual effect and then the psychological effect of the mastectomy would be easier. So at least 8 years ago, we started doing our first cases with what's called nipple sparing technique. And one of the things we do that's very interesting is that our incision is under the breast. So there actually is no visual incision that you can see on the breast itself. Oh, this is a wonderful thing because it basically hides the incision underneath the breast itself. All the breast tissue gets removed. The plastic surgeon comes in and does the reconstruction, maybe an implant or a tissue transfer technique where the breast used to be. And then the skin of the breast and the overlying nipple is put on top, and then it's closed underneath. And visually, it's virtually impossible to tell you actually had mastectomy. Breast cancer treatment has undergone many changes over the many years. When I initially started, the concept of a team approach was just not there. Not only was there not a concept of a team approach, the whole idea of a center approach was very unusual. Most women in those days would not have early diagnosis. They had a lump in the breast. There was no diagnosis of needle biopsy because people were afraid of sticking a needle into the tumor because it might spread things. And so you would basically go into the operating room, you would see the surgeon would remove the lump. In those days, because there was no early diagnosis and because there was only one procedure for this disease, you basically went to sleep not knowing if you'd wake up with one or two breasts, because the only operation was a mastectomy, was a radical mastectomy. So afterwards, because there was nothing to radiate, the radiation doctor wasn't involved in your care, because the chemotherapy options were very limited, there was virtually no chemotherapy. So that was it. And you were finished, and there was no reconstruction either, by the way. How wonderful it is to be able to say we've changed dramatically how we take care of things. And part of that is the idea that there is a team that's necessary. It's what we call multidisciplinary. You don't work in a vacuum any longer. I, as a breast surgeon, work with the pathologist, the radiologist, the radiation oncologist, the medical oncologist, the genetic people, the psychiatrist and psychologist, the social worker. This is a large group of people, and we all work together. People tend to think that this is a woman's disease, but in fact, men also can get breast cancer. And I think that men tend not to be very attuned towards their own bodies, and they certainly are not thinking that they will ever get breast cancer, but it is true, it can happen. Unfortunately, we don't have anything like early diagnosis. We don't do mammograms on men. We don't see them for breast exams on a regular basis. But I think it's very important that men should know that they could develop breast cancer, and when they develop breast cancer, it gets treated in the same way as it would for women as well. The symptoms that most men have when breast cancer is identified is some breast enlargement, actual mass. They'll feel something different about the way the breast looks sometimes, and there can be some physical twinges of pain. We've had innovators. We've had people here in our program over the years, and this goes back years and years. We have the top cancer surgeons who always ask the question, and you have to ask the question, is there a better way to do something? Because if you don't ask the question, you'll always be doing the same thing, and you'll always be stuck in the same kind of treatment that you've been doing for years. And so what makes New York Presbyterian's group of doctors so excellent is what they do is they ask that question. we're the only place in New York that is doing what we call cryoablation of tumors. Cryoablation is very exciting. It's the concept that we can actually keep you out of the operating room. And that's, again, because of early stage diagnosis and because of a small pea-sized tumor, let's say. We can put a probe in there and we could freeze that tumor, make that tumor completely disappear, and that can be done in an office setting. And I think that at the same time as we do the biopsy and get the biological characteristics of the tumor, so we've got that already in place, we then can freeze the tumor, and our pilot study right now is that we're still taking the tumor that has been frozen out to prove that, of course, all the cells are dead. But if we continue this way, and we can continue to have smaller stage disease, then this so-called technique of cryoablation holds a lot of promise for the right person in the future. You know, there's a whole bunch of radiation techniques about targeted radiation therapy. We're trying to become a center for targeted radiation therapy. This is done in conjunction with surgery as well, so that rather than doing whole breast radiation, which tends to be a standard, we've actually been offering patients shorter terms of radiation, and we're working again as a team approach with the radiation oncologists. I think that at the end of the day, surgery for this disease will disappear. And it's going to disappear because as we get smarter about the actual biology of the disease, we're looking to see what causes that one cell to become a cancer cell. But not only that, we're also understanding the mechanism of what that cell does. And there are research programs here at New York Presbyterian that are looking into understanding, can we starve that tumor? Are there hormones that we can give to make that tumor die on its own? Are there treatments that we can use to make that tumor cell just disappear? And as we get smarter in the research field, I think what will eventually happen is we'll have someone come in with a very early stage diagnosis. Maybe there'll be even a blood test for this, which we don't have yet, at which point we'll be able to say, okay, you are having something happening in the breast tissue. We don't like it. We're going to take those cells. We're going to study those cells. We're going to do a genetic profile of those cells. We're going to be able to identify exactly some of the biological characteristics of that cell. And then we're going to have medicine that will counteract those biological issues. And I think that's where the future is. No one likes mammograms. I hear this all the time. They're uncomfortable. They're scary. They're scary because you worry about what they're going to find. You hope they find nothing, of course. Afraid of also the compression and the potential pain. And I know that people have had wonderful lives saved because of those techniques. And I guess as more and more people learn that you can have a satisfying life, even if they find something in you, I think that might change people's opinions about being afraid of doing a technique that might save your life. I think that patients like to know that there is a team approach behind the decision process, so that not one person is involved in their care, but to know that there's a multidisciplinary care team that's going to take care of them. And that takes them through all aspects of care, which makes it very important. I think it's also important now that I think the people around the country, American College of Surgeons and other large organized groups of cancer care, have realized that there is an importance in becoming a center. And the center approach really makes a difference because people who are treated at the center tend to do better. And so there's now been an accreditation program that has begun over the last year or two.